All right, well, welcome everybody to this session of our PFRH Master's Essay presentations. I'm Sally Safi, I'm Director of Graduate Studies in the department, and I'll be facilitating today's session. We'll have presentations from 4 students, and I had the pleasure of advising all of them over the past couple of years. So I'm really excited to see them present today and have this be a celebration of all of their hard work and achievements over the past couple of years in the program. And so I will start out by introducing our first presenter, Deardhra McGeough-Prendergast. You can please correct me, I butchered your last name, but you come to us with a Bachelor of Arts in Political Science from the University of California, San Diego. Deirdre's area of interest is population and health, and she'll be presenting on her master's essay about mobilizing healthcare. So Deardhra, I'll turn it over to you.
Great, thank you so much. I'm trying to share my screen. Are you all able to see my screen?
Yep, looks great.
Perfect. So good morning, everyone. I am excited today to share the findings of my systematic review, focusing on the pivotal role of mobile health clinics in mitigating healthcare disparities in rural Appalachia and similar communities nationwide. Before I get into this, I do want to thank my reader, Dr. Wendy Bennett. She has been very insightful and helpful throughout this whole process. Before diving into this research, I want to offer a glimpse into my personal journey and why this topic resonates deeply with me. I grew up in a really rural town in Northern California. I experienced the challenges of accessing healthcare firsthand. Coordinating doctor's appointments was consistently burdensome, and accessing specialized care often necessitated a lengthy 2-hour commute. The local healthcare landscape was so limited that resorting to emergency room visits sometimes seemed like the most feasible option. These experiences have fueled my dedication to addressing healthcare disparities, which is why my research has been directed toward looking into the efficacy of mobile health clinics in serving underserved populations. Shifting to focus on the broader context of healthcare disparities in rural areas, these regions often grapple with a large amount of different health challenges, from limited access to healthcare facilities to shortages of healthcare providers and existing socioeconomic disparities. Why did I choose to focus on Appalachia? This area serves as a mirror reflecting on the healthcare struggle endemic to rural America. By honing my focus in on this region, I gained invaluable insights that inform strategies to tackle healthcare disparities on the national scale. In terms of objectives, my research sought to evaluate the effectiveness of MHCs in improving healthcare access, health outcome, and community engagement in rural areas. So on this slide, I will go ahead and highlight the key findings from my literature review. For my methodology, I employed a systematic approach to look into healthcare disparities prevalent in rural Appalachia. This involved establishing a specific search criteria and utilizing prominent databases like PubMed, Medline, and Scopus. Keywords that I used throughout this research included rural health disparities, Appalachia, healthcare access, chronic disease, and mobile healthcare clinics. The literature review revealed alarming trends in chronic disease prevalent in rural Appalachia, surpassing national averages. Mobile health clinics emerged as a key resource in bridging healthcare gaps. They provide a median of 3,491 visits annually, with over half of their clients being women and racial ethnic minorities. Notably, 41% of clients are uninsured, with 44% on public insurance, highlighting the extreme importance of these clinics. I would also like to note that in the literature, I identified that there was 279 rural counties that lack federally qualified healthcare centers or rural clinics, isolating 72 counties from primary care and safety nets. Through my research, I have uncovered compelling evidence of substantial health disparities between rural Appalachia and urban areas alike, as well as national averages. Obesity, cardiovascular disease, and diabetes rates in rural Appalachia significantly surpass those of urban areas in the nation as a whole. For instance, according to NCHS, the prevalence of obesity among adults 20 and over in rural areas in America was 34.2%. Similarly, the AHA reports that rural populations have higher rates of cardiovascular disease, risk factors such as obesity, smoking, and physical inactivity compared to urban populations, and the age-adjusted prevalence of diagnosed diabetes amongst adults 18 years and older in rural areas, which was 10%. These figures show the extreme health challenges that rural communities such as those in the Appalachians encounter. This graph depicts a sharp rise in chronic disease prevalence across the US from 1950 to 2020, soaring from a 7.5% to 60%, showing a strong need for accessible healthcare. In my research, I've explored how mobile health clinics like the Health Wagon, which is a mobile health clinic that is actually in the Appalachian, I'll go ahead and talk about that a little bit today, has addressed these types of disparities. The Health Wagon was established in 1980, and it provides vital healthcare services to thousands in an area where, like I mentioned earlier, 30% live below poverty and 20% lack healthcare insurance. Not only do these clinics offer a comprehensive range of services, including preventive screenings and chronic disease management, they also address prevalent health issues like obesity and diabetes, and foster community environment. So this is actually a photo from the Health Wagon, and something that I found that was really interesting in my research is that when you do live in a rural area, and this is something that I had experienced, and I mentioned, it's very hard to see a primary care provider. So often people will go to the ER, but seeing a specialist or even a dentist or something like that is really out of the question. So when these clinics can come to these areas and bring care to the doorsteps of these people, the really unique thing about them is that they often do have a specialist, like they'll have dermatologists or OBGYNs, and it's just a very amazing service. In my exploration of MHCSs and their effectiveness in addressing healthcare disparities, one compelling success story that emerged from my analysis is the Remote Area Medical Program, which is RAM for short. This one was founded in 1985, and it operates mobile medical clinics that provide free healthcare services to underserved populations across the US and around the world. Through RAM's mobile clinics, individuals in rural and remote areas have access to a wide range of health services, including medical, dental, and vision care, as I just mentioned. Supporting RAM's effectiveness in this upward trend predicted in the US mobile clinic market from 2020 to 2030. This trend that we're looking at underscores the growing recognition of MHCs as essential components of the healthcare system, with increasing adoption and utilization expected in the coming years. Excuse me. Data from rural areas highlight disparities in various health issues compared to non-rural areas. For instance, as mentioned, rural areas often have higher rates of mental health disorders, with approximately 20% of residents experiencing these symptoms of depression, compared to 15% in urban areas. Similarly, substance abuse disorders are more prevalent in rural communities, affecting around 10% of residents compared to 7% in urban communities. One contributing factor that I had found in my analysis for these disparities is the shortage of healthcare providers in these areas. According to the HRSA, rural areas face a significant shortage of primary care physicians, with approximately only 25% of rural Americans living in areas that are designated as primary care health professional shortage areas. This shortage not only limits access to essential healthcare services, but it also results in increased healthcare disparities and poorer health outcomes among these populations, continuing this cycle that I've dived into. Rural communities face a 21% risk of hospital closure due to financial challenges, exacerbating the healthcare access issues. Individuals in rural areas must travel an average distance of 30% further to access primary care services compared to urban counterparts. And I found this to be really interesting because, again, bringing this to a personal level, I grew up in an area where I had to travel to even 4 hours just to see a primary care doctor. Seeing a specialist was out of the picture. So the primary care doctor would have to take care of everything. And oftentimes when people have to drive this far, as we know, there's issues with transportation, getting time off work, having to watch the kids. So when that comes into play, people will overall just cancel the appointments because they can't make them tie into working with their schedule. So as we look into solutions, it's important to acknowledge why these mobile health clinics aren't as widespread as they should be, which I found, and I was pretty shocked to find that, because I think that these sound like such a great solution, and why aren't we seeing them everywhere? The hurdles are multifaceted: financial constraints, regulatory complexities, and logistical challenges hinder the establishment of MHCs in many areas, leaving communities without not only vital healthcare services, but any type of healthcare at all. But my research uncovered that there are a lot of different strategies that we can use to revitalize the impact of MHCs in tackling healthcare disparities head on. So one of the things that I found that a lot of different communities are using is the integration of telehealth. So as we know, telehealth has become very prevalent, especially in COVID times. But through this area and looking in rural communities, it really transcends physical boundaries, bringing virtual healthcare directly to the doorsteps of people. And especially people that don't have Wi-Fi or they don't have access to even do telehealth in their home. Again, coming to a mobile clinic or having a clinic, right in their community can really help close that gap. So I found that through video consultations, remote monitoring, and electronic health records, like I just said, MHCs bridge the gap in access to specialized care. Additionally, my research highlights the power of community partnerships enhancing effectiveness of MHCs. Collaborations with local organizations, healthcare providers, and community leaders maximize the impact in rural areas. Partnerships with schools, churches, and community-based organizations not only provide medical service, but they also address root causes of health issues, deliver health education, and build trust within the community. So through the research, I found a lot of different calls to action, and a clear call to action in my finding, and a common theme through a lot of the articles and data that I had looked at, is really urging stakeholders to take concrete steps to address healthcare disparities in rural areas. The data shows that the need for collaborative efforts from policymakers, healthcare providers, and community stakeholders to drive meaningful change and improve access to care for underserved populations is key. Recent statistics revealed that mobile healthcare clinics remain scarce in rural areas, and according to a national survey conducted in 2023, only 15% of communities reported having access to mobile health clinics in the South. So again, in highlighting the stark gap in healthcare services in comparison, we found that mobile health clinics boasted nearly double the availability of services with their rural counterparts. So another thing that I found, specific recommendations, again, that have worked in the past and that I would advocate for and continue to research, include advocating for increased funding and resources and support for these clinics. These clinics have showed promising results in enhancing healthcare access and outcomes in rural communities. Studies have demonstrated that MHCs can lead to significant cost savings, with every dollar invested in preventative care potentially saves up to $6 in future healthcare costs. MHCs have been associated with reduced hospitalization and emergency room visits, showcasing their value in promoting preventative care and managing chronic conditions. So in conclusion, my research highlights the significant issue of healthcare disparities in rural areas, which holds personal relevance, as mentioned earlier. I found that mobile health clinics serve as a vital resource to deliver essential healthcare directly to these communities in need and bridge the gap between those that can't afford healthcare or are not able to travel to access these resources. These clinics offer a wide range of medical services, from basic consultations to preventative screenings and chronic disease management, effectively addressing diverse healthcare needs. Additionally, integrating telehealth into the MHCs expands reach, enabling remote communities to access specialized care. Furthermore, my research highlights the importance of fostering community partnerships to enhance MHC's effectiveness. Overall, my findings emphasize the important role of MHCs in addressing rural healthcare disparities. By embracing innovative strategies and community collaborations, MHCs can extend their impact and promote health equity in underserved areas. And I think if we had more areas that looked into this, it would really close a gap that we are seeing for people to not have access to healthcare, and it would really bridge a lot of the problems that we are facing and in our communities today. And that's it. Thank you.
Great. Thanks so much, Deardhra. We have time for maybe one or two questions. Any questions? Deardhra, I guess I'll ask, what do you think are the biggest barriers to implementing the solutions that you presented, like implementing?
I think, yeah, one of the biggest things is in these rural communities, what I found and even what I experienced, aside from the financial issues, is that when communities are so rural, they sometimes don't have that access to maybe even renting a van or getting the medical equipment or getting providers. So it's really just those things, because sometimes, providers that don't live in a rural area, they don't want to travel 3 hours to be a part of this, or that's not in their contract. So it was really interesting to see when people are in remote areas, just the lack of even a basic foundation is what is, bringing such a huge gap in these mobile health clinics.
Great, thanks. Well, again, great job on your presentation. Thanks very much. We'll go to our next presenter. Tijani Salami comes to us with a Bachelor of Medicine and a Bachelor of Surgery from the University of Maiduguri in Medicine, and a Master of Public Health from Walden University. Tijani is in the maternal, fetal, and perinatal health area of interest in the department. And Tijani, I'll turn it over to you to present your essay on integration of men in antenatal care.
So thank you. Sorry for the itches there. Yes, thank you. Good afternoon. My name is Tijani Salami. I'm very happy to be here today. Today I'm presenting my thesis, which is a review of the literature of integration of men in antenatal care in Sub-Saharan Africa, which is a case study of Nigerian context. I work on this thesis with my leading advisor, Dr. Dominic Shatuk, and I'm very happy that he's been a very great support, and who has guided me so much in this essay. And I also want to say my background, that I'm a physician trained from in Nigeria, and I have worked in rural and suburban areas, working and strengthening a maternal child health clinic. So the thing I'm going to say, this study is not just about for study's sake, but it really speaks to my experience, and it speaks to what I used to do in the rural villages for over a decade. So, definition of male involvement in antenatal care, that's ANC. So, antenatal care is a journey that is centered on the health and well-being of the woman and child, and maintaining women's autonomy and promotion of respectful collaboration is the priority. It could be a journey that is shared by both partners. As this presentation will reflect, the research suggests that inclusion of partners, when done correctly, can improve outcomes for women and their children. Communication is central to the success of this process, meaning that this is communication about medical procedure, as well as in-home needs and care necessary to improve birth outcomes. So when I am discussing male involvement, the focus is on the ANC period, but it can be extended to consider how men can assist and facilitate a wide variety of care relevant activities. And these cares involve, one, location of delivery, that men will participate in location of delivery, postnatal and newborn care visits. It also extends to practical involvement, such as providing financial support, sharing household chores, and then planning for emergencies. Emotionally, providing continuous support throughout pregnancy and childbirth strengthens the bond between partners. By prioritizing women's autonomy, consent, and promoting respectful partnership, male involvement in antenatal care becomes a catalyst for healthier outcomes for mothers and babies and the families in general. So the background. We know that antenatal care is vital for maternal and fetal health. Over the past few years, a growing body of research has found that properly engaging men within maternal, neonatal, and child health services can have beneficial outcomes for couples. Those outcomes include that it fosters communication, it promotes gender equality, it improves family cohesion, and it increases maternal service uptake and adherence. Yet, limiting male involvement can hamper outcomes and perpetuate gender disparities. Despite initiatives, challenges related to gender norms persist. For example, men who embody traditional gender norms may not be willing to visit the clinic with their partners, and physicians are not trained to practice in providing counseling to couples rather than to a woman by herself. So, and the existing reviews that has been done lack a focused examination of male integration into antenatal care in Sub-Saharan Africa. That they focus on male engagement across a wider period of time, such as antenatal care period, the postpartum period, family planning, other reproductive health services. So this study is solely focused on the antenatal care antenatal care time period. So, and additionally, this study is focused on Nigeria, in Nigeria context, and I will discuss in the next slide. Now, objectives. The objectives of these studies are: one, first, to systematically review existing literature on men's integration into antenatal care in Sub-Saharan Africa, with a focus on Nigeria. And second is to explore the benefits and challenges of male engagement in antenatal care across Sub-Saharan Africa. And third is to provide actionable recommendations for policymakers, healthcare providers, and researchers in Nigeria to appropriately integrate men into ANC, using activities that have positive outcomes for women, children, and men. Through this study, we strive to contribute to gender-inclusive healthcare practices and improve maternal and child health outcomes in the region. The methodology, a thorough search for the studies was conducted across databases, which include PubMed, Google Scholars, and equivalent library. Search terms which were relevant to male involvement in antenatal care were used, and particularly in Nigeria context. And it was Nigeria context was included to ensure that relevant studies to this country was also included. Zotero bibliography software was used to organize the studies during the systematic screening and reference generation for the writing process. As you can see on the slide, the focus is on the recent and relevant literature. So I am focusing on studies that is less than 10 years old, written in English and conducted in Sub-Saharan Africa. And at the end of this process, I reviewed 91 studies. Just go quickly to results. The first result is identify positive outcomes for male income. My review in the literature found growing support for male inclusion in antenatal care. The study highlighted the importance of maintaining women's autonomy. Benefits of male involvement in antenatal care are, see from the slides, that Sunday reported increases in skilled birth attendance, modern contraception utilization, and postpartum visit. Study done by Odeni demonstrate a notable rise in antenatal care attendance rates from 43% to 57%. Sunday find that women accompanied by their husbands to ANC services are 58% more likely to utilize postnatal care. Odeni also revealed that a significant 17% increase in stillbirth attendant deliveries are also contributing to safer childbirth. Angulus Baskmi note that improvement in maternal health outcome related to safer childbirth, emotional well-being, and child spacing. Emphasis on the potential for promoting gender equity through male involvement in ANC was also revealed by a study by Chang et al. What are the policy implications for this result for Nigeria? As I mentioned earlier, the goal was to apply what was learned in the literature review to Nigeria and possible policy implications. But due to time limitation, I will highlight 3 of the policy implications I suggested in my paper. First, establishing policies that promote gender equity in antenatal care services. These policies should encourage male participation through flexible scheduling and tailored educational opportunities for men. Second, incentive programs originating in the workplace can elevate male engagement in ANC. Policies like paid time off and educational events at the workplace for expectant fathers can mobilize men to participate in ANC. Additionally, mass media campaigns that model men participation and express the value of caregiving for one's wife and child may be effective in challenging traditional gender norms. Last is establishing peer support network for expectant fathers. This may provide an opportunity for men to share their experience related to ANC and potential fatherhood. It can also increase communication around concern for fears associated with challenges during pregnancy, establishing a support network for men. These policies collectively aim to enhance antenatal care accessibility and quality. ultimately providing maternal child, improving maternal and child health outcomes in Nigeria. So the second results of that so noticed were integration challenges. Program designers must take into consideration elements like cultural norms that are informed by assumed gender roles and norms related to masculinity and how men have been involved in this life event in the past. Stigma and fear that many individuals have about medical procedure and health facilities in general. Health system limitations such as services designed primarily for women hinder effective male engagement in antenatal care. Societal expectation of masculinity must be explored before moving forward with this work. It's important to remember that many men, this is something that has not been modeled for them. They go to health center in extreme cases of illness and injury, and very few men no, very few men are aware of antenatal care appointments. The educational element of this change are significant. Initiating a conversation on sensitive topics is always challenging. Asking to be included in the ANC process is not different. So addressing these challenges, we will take into consideration a comprehensive approach that involves community engagement, gender-sensitive education, policy. So in conclusion, due to limited time, I will also focus on four of my paper's conclusion. First, the literature support the integration of men into ANC services, as this can improve maternal and child health outcome. Second is engaging community members to promote male engagement in ANC services is key. As I mentioned, like media campaign, and this work can reduce stigma associated with men's participation. The third is suggested that including men in ANC can foster increased level of family unity, potentially ease men into caregiving roles and promote their overall engagement in the home. And last is engaging men in antenatal care must prioritize women autonomy. It's very important to prioritize women autonomy, consent, and challenge gender norms. This will foster inclusivity and support for maternal and child care here in Nigeria. Thank you very much. My appreciation goes again to Dr. Dominic Shatu. Thank you for your patience. Thank you for all that you have done to provide mentorship. I'm very grateful. And appreciation also go to Dr. Sally Safi and Dr. Farah Qureshi. You have been a wonderful advisor to me throughout my MSPH journey, my family and my friends, my family for providing space for me to do this work and all the things that I've done for my MSPH journey. Thank you.
Thanks so much, Tijani. Great presentation. Again, I think we have a time for a question or two. Donna, go ahead.
Thank you, Tijani. Well done, and congratulations on finishing. I remember talking to you when you were applying to the program, so it's great to see you being finishing.
Thank you.
So I had a question. You found 91 articles, and I've been searching some of this literature recently for my course in the summer, and some of it is observational, is based on observational studies. So I wondered how many of the 91 were actually randomized controlled trials or good quasi-experimental designs, because I had the impression from some of the literature that there are some negative findings, and not that things are worse, but that there's not an impact of male involvement. So I wondered whether or not you actually looked at the subset of randomized controlled trials and the studies that you evaluated.
Yes, I look at those. Actually, most of the papers were visually cross-sectional survey, pilot studies, and reports from reputable journals, and only very few use randomized control trial,
Right.
which I can find the number now, but they were less than 10. And
Right.
And I also found out that yes, there was some also reported of no impact in the studies. Yes, I saw some quite number such report. Thank you.
Yeah, no, because I mean, there's certainly the issue of males who are involved are going to be sort of a self-selection factor rather than sort of the some of, I think, the approach that's used to try to educate and to get males more involved in the randomized control trials. Thanks a lot. Nice job and congratulations.
Thank you. Thank you.
We'll take one more question, Amy.
Yeah, thank you so much for the wonderful presentation. Maybe I have a question related to kind of challenges for implementation that you mentioned, like also norm stigma. You mentioned like media as one of the tools to tackle these challenges. Coming from like a perspective of physician, like what are the other solutions that you have in mind to tackle these challenges for this and those programs to be successful?
Okay, so, well, I talked now from my experience in the rural areas and as a physician that have managed maternal and child health clinic. There's need for community engagement. So when communities are involved, first we must start from the community before even the healthcare facility. So when communities are involved, like in Nigeria, when you bring in the gatekeepers like traditional rulers, religious leaders, and they change the norms, the beliefs, and they understand that men's contribution in ANC is important, that's change start from there. And then you can come to the healthcare center to train physicians, because physicians, healthcare providers generally are all focused on women. They are not provided the techniques or the skills to be able to counsel couples or the man particularly. So this overall for holistic approach like this will bring change. Yes.
Thanks again, Tijani. Great work. We really appreciate hearing your insight and expertise on the subject. We will go now to our third presenter. Kristen Alicea-Jorgensen comes to us with a Bachelor of Medicine in Molecular and Cellular Biology from Johns Hopkins. She is in the women's sexual and reproductive health area of interest, and she'll be presenting today on lived definitions of intersectional stigma, discrimination, and violence. So Kristen, whenever you're ready.
Thank
Looks
you.
great.
Can everyone? Okay, perfect.
Yep.
Thank you. All right. So hello, this is my master's thesis. It's a study proposal looking at lived definitions of intersectional stigma, discrimination, violence, and findings from cognitive interviews with gay men and other men who have sex with men and transgender women. I'd just like to say the biggest thank you to my advisor, Dr. Sally Safi, and another big thank you to the incredible peer team here at Hopkins. This work would not be possible with you, but this thesis would not be possible without the support and encouragement of Dr. Stephan Barral, Dr. Sarah Murray, Dr. Caitlin Atkins, and Kylie Willis. So first, before I get into my study proposal, I just want to acknowledge my positionality as a researcher. So as a researcher, I am Hispanic, Latina, and white. I'm a cisgender woman. And in doing this work and conducting these interviews, it's possible that I might share some identities with the participants, but largely recognizing that I'm not going to share all of my identities with the study participants, and especially moving through and analyzing and thinking about how this proposal might change. Just wanting to recognize how I'm coming into it as a researcher, but also, kind of discussing how work that reframes the narrative is something that I'm really interested in. And when joining the peer team and joining on this project, I felt that this was a wonderful opportunity to kind of see how reframing the narrative and bridging lived experiences kind of come together in public health research. And also just acknowledging that the work that I'm contributing to is a small part of a much bigger project that has been done by the Emory and Johns Hopkins team, which comes from an incredible and diverse group of individuals. So to get into what the project is, currently every year there are 2 cross-sectional surveys that go out. One is AMIS, one is TWIST, and they both are looking at sexual health trends. AMIS specifically for gay, bisexual, and other men who have sex with men, and TWIST for transgender, transfeminine, and non-binary people assigned male at birth. What's great about these surveys is that in going out every year, the research team that are contributing to these surveys will look at the questions that are proposed and either change, add new questions, or just kind of shift around how this survey is done. So it's something that's kind of reflected on every year. And questions that have recently been added and what I'm going to be taking a look at are questions specifically related to intersectional stigma, discrimination, and violence. So these questions were recently added, and as a result, the research team wants to look at, okay, how are these measures kind of being understood? What ways can we better them? And the way that we're going to do that is by inviting past Amos and Twist participants to complete a cognitive interview that'll be done over Zoom. And just to kind of go into what a cognitive interview is, it's a qualitative research technique to assess survey quality. So it really measures 4 things in the questions that it asks participants: content comprehension, how's content retrieval, the content that the survey is presenting, how is it being judged, how acceptable is it, and then how easy is it to respond to the questions. So this is the technique that's going to be used to assess the current stigma and discrimination questions in Amos and Twist. So where does my proposal fall into this? I'm proposing a specific analysis for one question that's already in the approved interview guide, which is, using your own words, what comes to mind when you hear the phrase stigma, discrimination, and violence? So kind of an end product or kind of conception of how this research question fits into the larger project is understanding how participants understand and conceptualize stigma, discrimination, and violence, and kind of compare it to how academic understandings really view it and implement it. So just to tie it back into Amos and Twist, analysis done with this question might shift the way that questions are asked or the way that questions are presented, or just provide new questions to ask participants instead. So kind of grounding the research and what kind of came to my mind in trying to decide and figure out what I wanted to analyze from this guide and kind of how I conceptualized this proposal was really the idea of lived definitions. And a research paper that I think does this so beautifully is by Moses and et al. At the IBIS reproductive health team, where they took a number of stages of formative research and developed a customizable electronic survey of sexual and reproductive health for transgender and gender non-binary people. So the end product of their work was a customizable survey that allowed for intake patients in a sexual and reproductive health clinic space to see kind of reduced definitions of what we would kind of ascribe very medical and anatomical definitions that might be stigmatizing or discriminatory or even lead to gender dysphoria events of gender minorities in these spaces seeking care. And so what they did is they allowed the participant and so they allowed the patient to kind of customize the survey so they could either consent to using the word that was presented or substitute in. And for the rest of the survey, they would see this. And I think this is just such an innovative way to kind of bring in personal experience into a very complex space such as medical care. Additionally, recognizing that what the questions in Amos and Twist are really getting at is intersectionality. And one of the things we're prioritizing in these cognitive interviews is learning how people answer questions and what identities are at the forefront of their mind when they're answering these questions, because it's going to be different for everyone. No person is the same, and understanding how they kind of come together and interlock or play on each other. So also recognizing that intersectionality is a large part of this research and will be a large part of the analysis. Lastly, also just to tackle the really complex definition and concept of stigma from its, historical and original kind of conceptions, with Goffman being very much an us versus them. It's very individualized, to more recent ones such as Lincoln Phelan, which go, no, it's not just between one or two people or one person in a group. It's something that is reinforced in many different ways in society, individually, communally, institutionally. And additionally, it's a process, to even more recent, Stengel et al., in that recognizing it's a process, but also that stigma can both be experienced and perpetuated by the same individuals or entities. And this is just to show that stigma is a really complex and ever-evolving concept. And this is just a space in this proposal as a way to bring in lived-based definitions into this space and add to the growing understanding of what stigma is. So what is the process going to look like? So we are currently starting to conduct interviews. So we're going to be going through all the different interviews, transcribing them, and then my specific proposal is going to be in the analysis and how we're going to do the analysis, which is going to be using episode profiles. And now I'm going to take you through what an episode profile is. So an episode profile was developed by Mayetta et al. In Sort and Sift, Think and Shift, which is just a research paper that talks about how to do really in-depth vertical analysis using an episode profile, which really centers individual participants' quotations and really analyze those as opposed to kind of more the big picture. So this will take a specific quote and find quotes associated with it, or answers to a specific question, which will be centered here, as you can see on the slide. So that'll be the center kind of part of the analysis. What is the participant's response to this question? Next, surrounding it, section quotations. This will be a space that I can bring in different parts of the participants, the rest of the interview, discussions that they have about the different identities to add in that intersectional piece and how they're kind of understanding and answering questions. Additional quotations that might refer back to what they said in this space, or just other quotations that seem to really align with their response to this. Then a space for interviewer memos, just to document how the interviewer or person doing the analysis is kind of thinking through and what thoughts they have in doing this work. Diagram memos to kind of spatially think about everything that's being analyzed. Then a section for topics, which is kind of going to serve as a proxy for themes and codes. And then lastly, a little summary section to kind of zoom out of the vertical analysis of this one participant and everything they're discussing to then go into more of a horizontal analysis. So take multiple participants, see what themes seem to be coming up, what themes are dissimilar, and kind of do a cross comparison. And this is an example of what it might look like filled out, and just the current iteration of what this episode profile looks like. So what are the strengths and limitations of this proposal? There's no change to the parent study, and it's already nestled in specific aims. It really focuses on vertical analysis to center personal and lived experience, which is what's so great about an episode profile. It's really taking a look at what the participant has said. And because it's kind of a rapid analysis technique, it can be done concurrently to the study to really remain center in the work. So in starting the interviews, this is something that I can kind of pick up and start doing day of or day after. And then taking into account the limitations, timeline, we are currently in the process of recruiting, and it's incredible. We've been able to get a first few interviews on the books, but we don't know how the entire recruitment process is going to go and what that timeline will look like in the long term. Additionally, acknowledging that the interviews are going to be done over Zoom, which is great to kind of get a national representative sample, but it also means that participants do need access to the internet, to a computer, and ultimately a safe space where they feel comfortable engaging with this topic and these questions, which are sensitive. And then additionally, the nature of the cognitive interview. The cognitive interview is really for the purpose of assessing the survey. So that means that participants can really only respond to the specific pre-approved questions. It's not similar to an in-depth interview where you can kind of let the participant go on and ask questions to kind of see where they want to go and kind of leave it open. It really is about getting the responses to those specific questions. But just to say, this has been a really exciting project, and thank you to everyone for coming. So if there are any questions or discussions or feedback, I'd love to hear your thoughts. So thank you.
Great job, Kristen. Thanks so much for taking us through that work. Who would like to ask Kristen a question? And Kristen, do you want to stop screen sharing maybe?
Yeah.
Just so
Thank you.
I have a question for Kristen. Kristen, great job. That topic is actually very special to me. And so I wanted to see if there were, I guess, like anything that you noted in the positionality of queer people of color and how they kind of move through queer spaces and how they felt othered or they felt sexualized or exoticized, or on the other ladder, like unwanted in the lens of desirability.
Mm-hmm. No, that's a really great question. And that's something that I think will really play into I think it's something that I will take into account when analyzing my specific question. And I think places that it can really be drawn in is in the guide. We have kind of proposed questions and then the responses, what identities come up for you when answering this question. But to your point, a limitation is that a lot of our questions are kind of in day-to-day discrimination, major events of discrimination, and then also anticipated discrimination, but none of the questions really talk about sexualization as a part of it. So that's something that I think we can discuss as a team and incorporate in, because to your point, that is something that is really valuable and needs to be analyzed. But to my knowledge and thinking through the guide is not something we've taken into account. More examples of what we have are, because of who you are, have you ever been worried about entering into like doctor's or physician's office? It hasn't really been on more of a social side, but that is something to kind of get at that possible within group stigmatization. So you bring up a great point, so thank you.
Hi, Kristen. If I could ask a question, Anais Williams here. Great job. This was so awesome, and I loved hearing about it. Yeah, I was wondering if you could just speak a little bit more about your sample and like sort of what you think your findings sort of represent and generalizability, and yeah, just wanted to hear a little bit more about that, like geographically, that sort of thing, if you could speak a little bit more.
Yeah, I can definitely speak about that. I know this is the first time we're doing cognitive interviews for Amos and Twist, to my knowledge, but in previous cognitive interviews and interviews that's been done with other projects kind of related to this, one of the great things is that it has been a nationally representative sample from all 50 states and Puerto Rico. So in terms of the sampling process, I know that our current initial aim is to interview 40 gay, bi, and other men who have sex with men, and 40 transgender, transfeminine, and non-binary people who were assigned male at birth. I think in the process, because it's like such in the beginning, we are looking for that maximum variability when it comes to participants, but we're not necessarily going to be turning participants down that I know of in terms of looking at different identities, but also recognizing that in this study, because it's going to be mostly on Zoom, and in my knowledge as an interviewer, I don't think that we're necessarily going back to their Amos and Twist interviews and really kind of trying to target different areas of the US or people who indicate different identities. It is very much just if you're interested and you want to come do it, please do. And we'll be sending out a number of different emails. And I imagine if we feel that an area might be underserved geographically or like urban versus rural, we might target emails more there. But that's my initial kind of knowledge and conception of how the sampling is going to go. Thank you for that question.
Great. Thanks so much, Kristen. Great job again, and great discussion. We'll turn now to our last presentation, which is from Shariq Farooqi. Shariq comes to us with a Bachelor of Arts in International Affairs from the George Washington University. They are in the women's sexual and reproductive health area of interest, and they'll be presenting their essay on shifting paradigms, examining gender roles among Nairobi youth. So Shariq, take it away.
Awesome. I'm going to share my screen now. Let me know if you can see that. Can everyone see that?
Yeah.
Perfect. Okay, so first of all, I want to thank everyone for joining me. Today, we're going to talk about specifically the study that I was lucky enough to be a part of, navigating gender norms amongst youth in Nairobi. I would be remiss to not thank the Johns Hopkins Center for Global Health for allowing me the opportunity to travel to Nairobi, as well as the Bill and Melinda Gates Foundation for funding this project. Some of the other organizations that were involved are below. And first, I want to acknowledge my positionality as a researcher in the Global North, studying at the Johns Hopkins University on Indigenous land. I also want to acknowledge the positionality of this Global North institution and engaging in global health research. I want to thank Dr. Anais Williams for being the best essay reader, the most gentle and patient essay reader I could have. I want to thank the PI, Dr. Michelle Decker, and Dr. Shannon Wood for supporting, and my amazing advisors, Dr. Farah Qureshi and Dr. Sally Safi, and of course, my amazing loved ones, my family and friends for supporting me on this journey. So first, I'm going to kind of go through the structure. So we're going to look at the intro and the context into what gender norms are, the study itself. We're going to look at the methods. We're going to look at the gender norm measure, the composite norm measure that we use for the study, as well as digging into some of the results, looking at, what that means for implications, and then some limitations. So looking at gender norms as a whole in a greater big picture, this definition kind of operates in a binary, meaning that it looks at gender through the lens of binaries with men and women. So I just want to acknowledge that. So gender norms operates a part of a larger gender system, meaning, there's gender attitudes, there's gender norms, there's, patriarchal norms that are entwined, and the way that power is distributed through men and women, and as well as the roles that they're allowed to take up within society and within different environments, kind of encapsulates what gender norms is. And gender norms doesn't operate in a silo, right? There's intersections. We see with Kimberly Crenshaw's definition of intersectionality, it intersects with race, with gender identity, with class, with social status. And so within Nairobi, it's ever evolving, but I think it's really keen to acknowledge the history and legacy of colonialism and capitalism and how that has embedded some rigid norms within the society. But since Nairobi is such a youthful city, those gender norms are ever evolving. And so what does that mean on a day-to-day basis? Specifically, we're going to be looking at youth. And so in the life stage and life stage framework, we see that it can affect their access to resources. We see that it can affect how they go about education, what kind of healthcare and the treatment that they get in healthcare, as well as the time use that they have, as well as economic workforce and more. And so looking at the study as a whole, so the study is a part of a greater collection of studies called Performance Monitoring for Action, PMA. And so PMA looks at reproductive healthcare indicators as well as gender equity indicators in order to improve policy. So these indicators are measured to guide the country's policy, and it operates in about 10 countries. And we're specifically going to zone in on Kenya within Nairobi itself. And so PMA Agile 2 is the second phase of a study that was done, and that data collection for PMA Agile 2 took place within last summer between June and August of 2023. Within this study, it was a respondent-driven sampling study that was consisting of a longitudinal study that had a previous cohort from the last study that was done for PMA Agile. And some of the indicators that we measured was family planning, contraceptive provision, GBV, gender-based violence, and gender norms, which I will focus on. And the sample was about 1,702 participants. So this had to account for attrition and aging of the population. So there was a replenishment sample. And so this would bring us to 870 men about and 830 young women. And so the format of the study would be in-person interviews at about 7 sites that were concentrated in low-income areas in Nairobi with the option of going remote. And so we're going to look at gender norm measures in terms of how did we measure the perceptions of gender norms. And so before I get started, I really want to emphasize that these are not the norms that the youth hold. This is the perception that they have of the gender norms within their communities. And so we looked at this gender norm set that we took from a study that was originally done in Bangladesh and Ethiopia. And it was a set of statements or questions looking at community restrictive norms. And they were divided into categories. For this specific study, we looked at 4 categories in particular: education, economic empowerment, time usage, and sexual and reproductive health. I'm not going to read all the statements out, but one of the questions was, our culture makes it harder for girls to achieve their goals than boys. We talk about whether adolescent girls are more likely to be out of school. And then the response options were according to a Likert scale, so meaning strongly agree, agree, neither, disagree, and strongly disagree. So these options would be coded 1 through 5 within our statistical analysis. This is the next section. So time usage, we're looking at the shared household tasks, whether that's equal, decision-making, and whether that's equal, and then what the community and what people in the community expect. The next section is economic empowerment. So basically, do men and women have the same chance to work outside of the home? And again, Likert scale. And then lastly, sexual and reproductive health, which is privy to what we're studying. And so looking at the power and control over daughters and sons' behaviors, which I thought was really interesting. And something that we also measured in the study was different demographic measures of these youth. So the youth sample was comprising of ages 15 to 29. And so with the age groups, we split it into 3 categories for the purpose of the paper. So I had 3 categories listed here. Gender, and I put an asterisk because I want to note that this is measured in a binary again. And so what that means is that we're looking at it only through the lens of men and women. And so this leaves out gender non-conforming and gender diverse populations, which I think is really important to know. Next, we measured education with highest level of schooling and current school status. Again, binary variables, whether they're in or out of school or whether they achieved below or above secondary education, occupation type, whether they've had paid work within the last 12 months, perception of their wealth, whether they're married or unmarried, dating a sexual partner, whether they've had one, and whether they live alone or not live alone. And then we also controlled for municipality of Nairobi. And there's too many to account for, so I can't list them off right now. And the analysis that we did, so we did this through Stata. So Stata was the tool that we used, and we did both a bivariate and a multivariate analysis. The bivariate we would use to assess any gender differences for each of the gender norm questions to see if there was any. The multivariate analysis would kind of capture whether or not there was an effect between any of the major demographic indicators that I just listed and gender and how they responded to those gender norm statements or questions. And then the composite score basically would sum up each participant's scores, and that would range from 12 if they answered 1 for every question, or 60 if they answered 5 for every question. And the higher the score, the more aggressive. And so we find with the key findings with demographics, I thought it was interesting. Most of our sample was between the ages of 15 to 19 years old, approximately 39%. And the next categories would follow by age. We saw that there were gender differences within current school status. So about 58% of participants in school were men compared to a lesser percentage for women. We see that most participants had completed secondary education. We see another gender difference in that folks that had found paid work in the last 12 months were men with 53%, and then most of the participants had a dating or sexual partner. Within the gender norm findings, there's too many to include all of them, but I included the 3 statements that had gender differences that were statistically significant. So what does that mean? It means that the p-value is below 0.05. So we find that 2 of the statements within the education category had statistical significant gender differences. We see that women were more likely to agree that there were regressive norms around whether it would make it harder for girls to go to school. So we see that with these first 2. With the last one, with time usage, it's about most people in my community expect men to have the final decision at home. So decision-making authority, we see that women are more privy to see this. And so it acknowledges the regressive norms amongst men. And so with multivariate linear analysis, we see that actually gender was not found to be statistically significant in terms of affecting how folks respond. It didn't play a huge role, but there was 3 questions where it did. And then with demographic variables, we found that the age groups of 20 to 24 and 25 to 29 were overall more aggressive actually as compared to the 15 to 19 age group. And then after adjusting for different demographics and gender, we also noted that the employment type of self-employed were more likely to actually be less regressive or report less regressive norms as compared to those working in formal employment. And so these are just some limitations that I found in areas that I think we could delve into deeper. The most pressing for me is that there's no data on gender non-conforming youth and gender diverse populations. I think this is a huge gap in that this could be a further area of research that we develop. I think as there's more and more data coming out on gender norms, it's important to encapsulate that gender is not on a binary. I think it's also important to note that maybe there could be further access on whether there's connections between the norms and how youth operate on a day-to-day basis. How can we make those connections? Also, I thought there was, a lack of gender norm questions around gender roles in parenthood and how gender roles show up, because we see that parenthood can be very gendered, right? How they're showing up in childcare, how they show up at work. And then lastly, since the study again was primarily focused on collecting what youth thought their community gender norms were, it wasn't their actual attitudes themselves. So another study or more research on the actual attitudes of Nairobi youth can also be done. And in conclusion, we found that Nairobi youth were actually perceptive of the regressive norms within their community, specifically within the categories of sexual and reproductive health and economic empowerment. And although we did find some gender differences between Nairobi young men and women, we found that overall gender did not differ in terms of the overall norms and the composite score. And then lastly, of course, Nairobi youth are still really redefining and challenging gender roles. When I had my time in Nairobi, I found it really fascinating and how amazing these youth were, and how I was able to engage with them and just see them on as a fellow youth myself on a youth basis. And then lastly, I really want to note that we look at gender norms through a Western and global North lens, not lending to the fact that cultural norms can lead to gender norms being different across cultures. And so cultural norms and gender norms shouldn't be always seen through the lens of what gender equity looks like through a Western lens. Thank you.
Great job. Thank you so much. Have time for a couple of questions. Chloe?
Yes. Hi. Hi, Shariq. Thank you for the presentation. That was really amazing. I just had one question in terms of relating to your limitations that you had discussed. So I guess how would your research have changed if you were able to accommodate gender nonconforming youth into your research?
I think it would change greatly, and thank you Chloe, for that question. I think further it would involve, changing that gender norm set that we use, because again, it was looking at it in the lens of men and women and that was in a binary of how they spend their time outside of home. And I think it could lead to more nuance in terms of looking at what are those lived experiences of gender diverse folks and gender nonconforming folks and trans folks, in terms of how are their barriers, how do they look different? Because there's a level of specialization that needs to be, I feel like, given to gender diverse populations in terms of their lived experiences being amplified in terms of their obstacles and struggles. And I think it's important to give those questions their own set. And so I think we would have to kind of change the question and the statement set completely. Thank you.
Thank you.
Any other questions? Could I ask you to expand a little bit on that very last point that you made in terms of gender equity, like looking different across different cultures?
Yeah, thank you, Sally. I've been very vocal in my classes about this, but I think it's really important that we acknowledge that oftentimes in reproductive health and population health, the spaces are dominated by white women. And so looking at the lens of what gender norms is in each community is going to differ. And so when I was in Nairobi, I made sure that I was taking a backseat as someone that wasn't a part of that community, that didn't have that lived experience. Because again, that I'm not privy to what cultural norms that they have, and I wanted to learn. And so what I noticed is that it looks different from even my own ethnic background as a South Asian. Our gender norms are also different. And so that doesn't necessarily mean that there's, there is gender inequity, but how can we look at it through a nuanced lens of, yes, there's patriarchal norms, but also there's deeply entrenched religious and cultural norms that are not necessarily equitable in terms of the lens of Western feminism and Western notions of what gender equity looks like. But for us, that's something that we're comfortable with. And that's something, but that is not to say that you can't criticize within your own culture and you can't, have expectations for improvements. But that's what I mean. I feel like there's a nuance of analysis, of layered analysis that you can have. And I feel like it just points all back to like intersectionality.
Great. Thanks so much. All right, well, that concludes our time together today. I want to thank each of our presenters again, congratulate you on a fabulous job today, and congratulate you also on finishing the program. So I hope everybody has enjoyed this series of master's essay presentations over the past few weeks. We're all very, very proud of our students, excited for their next steps, and hope to celebrate with some of you at our graduation celebration next Tuesday. But great job, everybody. Thanks so much for joining.